This next presenter, I cannot say enough good things about this man because he is my big boss and I want him to like me.
You don't have to do that, Josh. It's okay. I'm not that fragile, I promise.
This is Anthony Jackson. He is the Director of Prevention and Early Intervention Services at the Tennessee Department of Mental Health and Substance Abuse Services. And he is going to talk about Tennessee prevention programs and substance use trends. And he loves data, so if you have a notebook, I would suggest you get it out.
Oh, Josh, thank you. I'm always so excited to present, and even in these COVID times where it's really cool, I can see how many people there are. I see that we have 358 total participants, which means this is being really well attended. So I'm really proud of you guys for being able to put this together. I will say this, there will be data components of this presentation, but we've broken up into kind of two parts here. Because one goal is really kind of to make sure people are aware of what's going on in the state as it relates to programming, right? And then the other side of it is for us to then let's focus on the opioid issue. And my focus here will be students. And so I have a couple of slides on a student survey and some of the results. So then going from there, Josh said it, I am the Director of Prevention in the Tennessee Department of Mental Health and Substance Abuse Services, as you can see there on the slide. And really, what in the world does that mean? That means I oversee our primary, secondary, and tertiary prevention programs, right? And I could really appreciate when I got on, I was able to hear about certain service programs and the role they play, because that's one of those areas to where, as a state, I think we're getting better in understanding the value in working with those type of programs. And so from there, I'm going to talk about what we have programmatic wise, and then we'll get into the data. So what's the whole point? Well, you do evidence-based prevention, right? That's what you want to do. If you get federal funds, your fiduciary responsibility is for the work that you do to be founded in some type of evidence-based process of some sort. So what is prevention? You know, in regards to substance use and misuse, it's really, how do we engage people, right, to prevent them from doing something? And I think it's hard sometimes to measure what that looks like, or even what the results are, because really, how do you measure something you don't see? You want to prevent it from happening, right? But really, what we really go out to do is make our best efforts to identify who we need to engage with and why we need to engage with them, and then implement evidence-based programming around those thoughts. And so looking at it, I mentioned it before that I'm kind of in this prevention side. So I'm in this blue part of this semicircle, I guess. And really a lot of what my work does is we have indicated, selective, and universal. I'll define each of those in a second, because some of you all might not know what that is. And then you see we get to the treatment and recovery side. And what we're seeing so much with prevention is we're getting closer to being where we do primary prevention, right? That's where we engage people before they start using substances. But this tertiary prevention piece, which is relatively new for my office, to tell you the truth, where we are doing this overdose prevention piece. But if you're engaging with people from an overdose prevention perspective, you get closer to that treatment side, because you might have opportunities to engage individuals and help get them to treatment, or do harm reduction strategies, which we'll talk about. So what population should be the focus of prevention? You know, the fun thing about data is someone has done some type of analysis that likely will help guide your thinking. And so the reality is half of all lifetime cases of mental and substance use disorders begin by age of 14, and 3/4 begin by age of 24. So what's the data tell us? Well, we need to engage before 14, right? And we need to keep on engaging up until the age of 24. That increases the likelihood that we will have success, that we'll have individuals that do not develop a substance use disorder later in life. And really the whole point of that is you allow brain development. It's that simple. You allow brain development, you allow somebody's ability to make decisions, to be in a place in which they know what's going on. And so, as I mentioned next, you know, really, if we can get them before 25, we're in a really good place, because at that point you won't have as high rate of use, or really truthfully opportunities for as high rate of use. And then it goes in that decision-making capacity that we help define perception of risk. that's a big piece of what we want to do. I always say it's simple. What's my office do? We increase protective factors and decrease risk factors. Well, what the heck does that mean? That sounds like some gibberish. But the point is we want to educate people on, provide information, equip them with the tools. It's not just simply saying no. That doesn't work. I know I'm a why person. It's giving them the tools to help them understand. And that's where, again, we want to engage before 14 and really keep engaging up until 25. So when I mentioned before, or engaged in other high risk behaviors, because really at this point, we want to prevent it from getting past just simply early use or high risk use. We want to prevent it from getting further than that. Selective, that's engaging a little bit even before that. So we want to target individuals that are at higher risk, but they haven't started engaging in substance use. And then universal is kind of where it's really for everybody. It's the general population. It's not targeting any one specific group, but it still is getting information out there, providing opportunities for training and providing support. And so then I mentioned harm reduction, and that's, again, a new thing for my office. I think we started doing this work probably in October of 2017, at some point in that fiscal year 18 period. Yeah, probably like July 1, 2017. And harm reduction policy models, really, it's an alternative, okay? Because just simply saying you should be abstinent, that might not work. Because as mentioned with the SSPs, everyone is in a different place of recovery. Everyone has a different pathway to recovery, and recovery looks different for everyone. So all I did was say in 3 different ways the same thing is you got to kind of meet people where they are. You can't make them come to where you are, okay? And so unlike other prevention strategies, because I mentioned before that I do primary prevention where I try to prevent use, right? This is where we try to, include a set of practical strategies intended to change the negative consequences associated with use. Okay, some examples of harm reduction: courtesy rides for youth. That's an alternate activity. Distributing needles to individuals who use substances. That's the syringe service program, as mentioned before. And naloxone distribution campaigns where you're providing Narcan or naloxone. Narcan is the brand name. I try not to support brands per se, but you provide a life-saving substance to an individual, because fact is if someone's dead, they cannot recover. Okay, that's really the only position in which someone cannot enter recovery, is if they're dead. So that's really where we want to create an opportunity for people to get on their pathway of recovery. So harm reduction programs, they can be seen as controversial, and sometimes it's hard. And I will tell you, just even as an office or even as a division, that's something where education, working to knock down stigma, which I'll talk about later. And also, I think you guys are going to get naloxone trained, so you'll learn even more about it then. That's where you kind of have to engage people, educate, provide information on, and help them understand the value there. And some of it is people that have issues with it. They say, hey, you're just encouraging drug use. Okay, you're just saying, hey, keep on keeping on. And that's not it, because really syringe service programs, as mentioned before, but any other harm reduction strategy should also include opportunities for engagement, maybe brief intervention, maybe just an opportunity to provide resources to and talk about other activities, because again, everyone's on their own pathway to recovery. So now what I'll do is I'll talk about some of my kind of primary prevention programs. So programs for individual populations. So what we have, here's an overview. Prevention programs for individuals are evidence-based, right? I mentioned that before. And these programs target selective and indicated populations. From my office, these programs include the Tennessee Prevention Network, which can include our comprehensive ATOD, comprehensive alcohol, tobacco, and other drugs. Apologies for the acronym. In-home services for infants at risk, and pregnant and postpartum women's program, and other session-based, evidence-based programming. I always joke and say these are our butts and seats programs, okay, where it's like kind of like a dosage and duration situation where it's this many sessions over this period of time, and each session is this amount of time. And these are all evidence-based. They're based off of curricula that have been approved and been through that vetting process that shows there's some efficacy there if done in a correct manner. And so some of the counties served by these programs, you can see it's relatively statewide. You'll notice not every single county is lit up, but anyone from any county can access these programs. Okay, it's not restricted to you have to be in Shelby County to receive services, or you have to be in this county to receive services. No, no, you can access these services everywhere. In 2020, we served about 6,500 individuals that would range from youth to young adults, even some adults in around 45 counties. Breaking down Tennessee Prevention Network. So what are the goals? And you'll see kind of some repetition here because the concepts are consistent throughout. We want to delay the onset of substance use and substance use disorder. Okay, reduce illegal use of substances, reduce the prevalence of negative consequences associated with substances. And again, it's that primary prevention focus. And I'll readily admit we have that primary prevention focus due to our funding requirements. Simply put, is our funding for this program, not all programs, but for this program requires a primary prevention focus. So from there, nurses for newborns. The whole point of this is let's prevent infant mortality, child abuse, and neglect by working with new parents. Okay, and really what we do is we focus on infants who may face medical, social, or environmental risks. And the whole point of this is I talked about engaging earlier. How early can you engage unless it's a newborn, right? And that's really providing the supports for the family. Because again, what we want to do is reduce misuse of tobacco, alcohol, and other substances, and increase early identification and management of maternal depression. So the goal there is obviously to help support the child, but then also to help support the mother. And for these services, what we do is up to 2 years of age. Let's see here, Universal Prevention Program. So these are our coalitions, which this is sponsored by a coalition. Jack White, I think, is the executive director of this coalition. So coalitions are very important to me, and I'll mention the role they play in our system overall in a little bit. But coalitions, simply put, are partnerships where you bring together sectors of a community. And the reason why that's important is these are individuals that have a common goal. They live there. They want their area to have success or not have issues, right? And so these substance abuse or use, I'd rather call them use because the language does matter, but substance use prevention coalitions, in this part where they're funded through my office, they work to prevent dependence on addiction to harmful or potentially lethal substances such as prescription drugs, alcohol, and tobacco using the prevention framework. So if this was an in-person meeting, I would say, did you know what is a pack of male cheetahs called, or a group of male cheetahs called? My team thought this was funny. I didn't know it, but they're coalitions. So imagine these coalitions are packs of cheetahs. I don't know how they feel about that. But then, so I mentioned that the SPIF plays an instrumental role. The SPIF, the Strategic Prevention Framework, this is really the lens through which these programs operate, okay? Because I mentioned before, evidence-based is so important. You have to make sure you're following some type of structure when you deliver services, at least from my office or dealing with prevention. So this SPIF is that evidence-based structure through which their work is guided through. And so SPIF, simply put, it's a planning process, okay? It's a good way to work things through a process. There are 5 steps. I'll show you guys the fan in a second, but there are 5 steps, and these steps offer a comprehensive process for addressing substance use or substance misuse and other related behavioral problems facing the community in that given situation. But really, for the SPIF to be effective, people need to be in a place where they understand it. They understand the role it plays in taking it seriously, truthfully. Those are all very important in having success there. And so then here, I mentioned the fan a second ago. So here we go. Here are the 5 components, and then that kind of part in the middle. So we have assessment, capacity, planning, implementation, and evaluation. I'm not going to go over explaining each of these pieces, but you can see how that makes a comprehensive look at something. And then from there, that allows you to obviously work a problem and figure out what you're going to do, but then also look back on what you did and adjust as necessary. But really, in that middle piece, you see sustainability and cultural competence. That I feel like is always the key, and that's necessary for each step of the SPIF. And I think that's the key because that's what allows the work to be done, and work to be done in a way in which I always use this example. It's a lot better for and I'll use Jack and Josh in an instance because I can see Josh and I can think of about Jack right now. It's a lot better for Jack and Josh and their teams to think about what's necessary for, in this instance, Shelby County, than for Tony Jackson in Nashville to say, hey, we're doing this, right? So that's kind of where the cultural competence, they're able to understand what their community needs by way of working with their community partners, but then also they always have to have an eye on sustainability and how do we keep this process going if funding goes away and all of those unfortunate things. So let's talk about what the goals of these coalitions are. There are three goals for all coalitions. This is maybe the one consistent thing for all coalitions. They have a goal around binge drinking, a goal around tobacco, and a goal around non-medical prescription drug use. And obviously it's prevention for each of those. I know, shock. And so that's all of their goals. And so next we'll see a map, and you can see how currently we have 46 funded county coalitions. We added 5 new ones in FY19. I hope to be able to add more at some point. You know, funding is always a funny thing. We always shoot for having sustainable funding. You know, I follow the spiff also, you guys. I don't just make other people follow things. I follow them as well. But when we add coalitions, we want to make sure we have a sustainable funding source before we add them. So that's kind of where we've been a little hesitant to add coalitions in the recent year or so. And so there, let's talk about some of these specific discretionary grants that many of the coalitions implement. PFSRX, which is the PFSRX, let's give you an overview on goals. It's a multi-year discretionary grant, ran from 2014 to 2020. It builds on that spiff that I mentioned before, and the goals similar to what you saw before, right? Reduce non-medical use of prescription drugs and address emerging trends among persons aged 20 to 25. You see that 25-year mark again, right? That's really where, again, the science says that's what, if you had to put a stopping point or you had to kind of put an area where you're going to focus on more than other areas, it's up to 25. Now, it doesn't mean we don't do anything for anybody that's 25 plus, but that is kind of a focus. But then also reduce prescription drug misuse and abuse related problems and consequences. So from there, here are the counties that are involved in the PFSRX grant. You can see it's more of an eastern part of the state program. And then SPIFRX, very similar to PFSRX. And I won't read all this because I kind of just did a second ago for the other section. And you can see the counties here that are served. And then from there, our higher education initiative. This is where it's called CHASCO. I never remember the acronym, so it always has to be in front of me. So it's the Coalitions for Healthy and Safe Campus Communities. It's a statewide coalition. They work with 10 campuses. And what they do is they work to address high-risk drinking behavior on campus, drug use, and incidents of violence. Obviously, with the higher education initiative, you can see the thread. This is working to engage and provide support, provide information to young adults, in all likelihood, majority younger than or at the age of 25. Primary objectives, promote healthy and safe campus community, provide primary prevention services, and also connect and support institutions. I mean, that's the one thing with a lot of this stuff is connecting those peer groups so that they can maybe have discussions within themselves and learn from each other and develop potentially best practices. And below, you can see the 10 campuses currently that have prevention plans. So here are the counties served by CHASCO. And this is closer to statewide. And again, we're always looking to expand when we can. So the higher education initiative program goals, reverse Tennessee's upward trend in binge drinking, reduce binge drinking related consequences, and as mentioned before, support these colleges and also kind of bring them together so that they can have that opportunity to peer share, which is so important. So other prevention initiatives, I might breeze through these a little bit. Prevention Alliance of Tennessee, the PAT, that's what I term our coalition of coalitions, an opportunity for the coalitions to come together without the state having to bring them together. Because again, sure, we have an instrumental role as a state to play, but as I mentioned before, there's some value in the individuals that are part of the communities to come together and discuss things that truthfully I may not catch or even know about. And then the TCB as our Tennessee Certification Board. This is a way through which we try to support our state funded and also non-state funded programs to make sure that we have individuals in the field who understand prevention and have a certificate saying, hey, I have passed the test, I've done all the learning, so that demonstrates that I know what I'm doing. And then it's also a continuing education piece where people have to continue to get credentialed once it expires. So now let's talk about evidence-based practice work group with Vanderbilt. This is what I liken to our R&D group for my office, the research and development group for my office. What they do is they help strengthen the system by supporting programs. They help us make informed decisions because they have that research, they have that background in a lot of what making sure what we're doing makes sense. And also truthfully, it gives us an opportunity to put have someone else looking at what we're doing, because I could think, oh, this is fine, this is great, but having that outside perspective can make sure we stay on track. Also, another goal of it is increasing the knowledge of prevention providers. And then working to strengthen capacity and infrastructure. I mean, that's an ongoing issue so that we can kind of be aware of what's going on. And then if there's an issue, we can address it as such. Process to bridge the research to practice gap, because that's the big piece of it. Is they are the research people. They're not the program people. They are the research people. So they bring the research to the programs, right? We work with them to kind of let them know what's going on so they can kind of, again, run that through their lens, their perspective, and help guide us truthfully and provide support and help us, as I mentioned before, stay on track. They provide technical assistance. They do presentations, because sometimes truthfully it's better for them to do a presentation on the research than for me, because simply put, they might have a more of a background on it than I ever would. And then also they're able to get tools out to our providers and again, help support them to facilitate implementation of evidence-based practices. So now actually what I should have been talking about opioid related things, because this is an opioid summit, right? And so from there, as you see here, I've got 3 funding sources, kind of the state targeted response, the STR grant, the state opioid response, SOR grant, and then we just recently got the SOR2 grant and some other discretionary grants. So the STR and SOR prevention objectives, they're very similar, because what we did is we tried to build onto each as funding came and went or stayed. We tried to build on each of those opportunity to expand what we're doing. And so from there, one of the first objectives, provide opioid awareness and overdose trainings in every county in Tennessee, which we have done to this point, but we'll continue to do. And when you think about the focus population, it's first responders, okay? It's individuals at high risk of overdose, their families and or friends. Truthfully, SSPs were mentioned earlier. That's one of our biggest groups that we try to train on naloxone, distribute naloxone to, because that's where we have the most saves or reversals, and I'll go over that data in a second. And then also our other focus population are agencies or organizations that provide treatment, recovery services, or community resources, because that's where, again, there really is no one that we won't train that the ropes. I mean, you can ask Josh and Jill, they're your ropes in Shelby County. They'll train anybody at any time. Now that naloxone distribution piece, that's the harder side, because we don't have enough to distribute to everybody. But in terms of training, anyone that can get trained, that wants to get trained, will be trained. And that's kind of our MO or our perspective on that. Another component of these discretionary grants is implementing an advertising media campaign. But what we've done there is we let the communities do that, because again, I genuinely mean it when I say that there's no value in me from Nashville, from central office saying, hey, do this. That's where we work with these communities to make sure that it aligns with what will be useful and valued in those communities. Also development of resource guides on treatment, recovery, and social services, and working to keep those updated, because that's a big piece of helping people in that time of need. You don't know when you'll need it, but you need to have it ready to give to someone that needs it. Distributing naloxone to individuals at high risk, their families and peers, first responders, and then agencies providing treatment, recovery, or community services as resources as mentioned above. Let's see here. Number 5, um, coordinate timely on the ground responses to overdose outbreaks. That's a big piece where these regional overdose prevention specialists, they're the boots on the ground people. They're the people that can be in a place in a given time period. But a big piece of it is knowing about the overdose outbreaks. And that's the big piece of, if you don't know about it, what do you do, or how do you even do anything? So that's where OD MAP, which is available in Shelby County, which I know the ropes use, and I know that many other organizations in Shelby County use. That's where they're able to see things as they're happening, or even sometimes, hopefully, before they even happen. Then also 6, train healthcare professionals and students to assess and treat OUD. We're doing this through an ECHO model with Vanderbilt University, where every other Tuesday they will have it's basically a teleeducation multimodal approach where they'll have anyone that's a healthcare professional can log in and attend a session where you learn about these case studies. And it's a situational thing to help enhance MAT that's delivered, and help train people that maybe wouldn't have access to all these different situations. And then also we want to increase access to MAT. This is by way of emergency departments, rural areas, and recovery courts. And so from there, the next grant I'll mention is the 10 Save a Life First Responders Grant. You'll note it's not in Shelby County. It's in the 13 counties in Central Tennessee, including Rutherford County. And the whole goal here is educate, train, distribute naloxone, and coordinate referrals and services for individuals who have overdose or high risk of overdose. This is where we're trying to provide support to people in need in a given time when they do need help, and work to get them connected with treatment, because sometimes that might be the best time to get them there. Let's see here. So I've mentioned ropes before. Josh, who's doing a great job today, he's one of our regional overdose prevention specialists. We have 13 catchment areas across the state. We have about 20 to 24. It kind of comes and goes. And then also some are part-time, some are full-time. So I'm hesitant to give a real specific number on that. Their goals: harm reduction, reduce stigma, and increase public awareness. So harm reduction, I said it before, but I'll be a little more specific here. It's a way of preventing disease and promoting health, right? And meeting people where they are. That's the most important thing. If you don't learn anything today, just meeting people where they are. Think about it. You're much more likely to appreciate someone if they meet you where they are, outside of them meet you where they are, right? And that's where that's the kind of that give and take, where you do have to maybe kind of give a little bit. And truthfully, not everyone is ready or even able to stop drug use. So again, evidence-based, scientifically proven ways of decreasing risk are essential, and that be medication-assisted treatment, naloxone, and syringe exchange. And so what are the core principles of harm reduction? A non-judgmental approach, an incremental process. It's not just a change. It's not a light switch. It takes time potentially. Focus on enhancing quality of life, recognizing complex social factors, because these influence vulnerability to drug use and drug-related harm. And then empowering those who use drugs. And so you might, if you saw that all by itself, you might go, whoa, what in the world is this guy talking about? But really, the individuals who are actively using substances, they're really the only ones, because it's them, that can really be their primary agent in reducing the harms of their use potentially. And so then in reducing stigma, doing away with labels, using person first language. I think one thing that's hard is even the word addiction. So what's the etymology of addiction? Well, addict, shun. So it's kind of even not even using that word, using individuals who use substances. That's more person first language, right? Understand that drug use follows a continuum. Embrace positive change. Positivity matters. It really does. And also be aware of unintentional bias. I'll readily admit that's something that I work to be aware of all the time, because it's hard, because you don't know you're doing it. So it's either where you have other people check you and kind of say, hey, you did this, and what did you just be aware of, of that. And when you think about reducing stigma, sometimes it helps for people to reflect on personal experiences because that creates that connection that then helps them better understand or see. And then also understand that substance use could be linked to trauma, and that's no fault of an individual's own. Okay, it might be something external that happened to them. So how do we increase public awareness? Through trainings and through a media campaign. The trainings have four core components: the opioid crisis, harm reduction, reducing stigma, and how to administer naloxone, also tied to naloxone distribution component sometimes. And then also these media campaigns can be billboards, radio ads, TV commercials, maybe it's flyers. Again, this is where it's tailored to each region or community. So the TN Save a Life program, what we've done so far with ropes since October 2017. So it's 3 years old so far. Today, I realized that when I reviewed this, I kind of forgot it was October 2017. We've distributed over 170,000 units of naloxone in Tennessee. That's amazing. Guys, imagine in September 2017, it was zero. And so for the naloxone piece, in terms of reversals, and I think this is a bigger number to tell you the truth, it's 17,000 recorded saves. Those are 17,000 opportunities for someone to get on a pathway to recovery they wouldn't have had otherwise. And so I think that's incredible. And one comment I'll make is while I'm saying that the ropes did this, and the ropes have heard me say this before, yeah, they did it, but it's also a combination of, I showed you guys that kind of half fan or that semicircle earlier. It's a combination of those programs working together to help support each other and create opportunities. So here now I'll get into some data, Josh. You told me I was doing a lot of data. I'm only gonna do 10 slides, but that's okay. We did a student survey, and it was a great opportunity because I mentioned before, my focus has always been primary prevention. We try to engage individuals that are younger than 14, so on and so forth. So this student survey gave us some data to help frame our programs, but not even just framing our programs, but also to help those communities that participated in the student survey to get access to data that they hadn't had before. Before I go into too far depth of this, I'll mention one anecdote of this, which I think is important, is one of our communities, they did the survey and they saw the data on our evaluator, who's great, was going over it with them. And they said something to the effect of, so the age of first use is what now for this? Oh, it's this age. And this is actually, this is younger than other areas of our state. This school system upturned their whole curricula and realigned it to where they were providing support and information and education before that average age of initiation, because they saw an issue where, oh, well, they are initiating substance use earlier than we thought they ever were, maybe by a couple of years. So we need to realign our training, our programming to help provide support. So this survey surveyed youth in grades 8, 10th, and 12th. This is a survey that we do every other year. So we're actually in an administration year this year, and regardless of COVID and all that other, it's not fun stuff, we think we'll be able to have a successful survey this year. When we administered it the first time, I think we surveyed over 21,000 kids across the state, which that's an incredible number to me. And I think we had a total of maybe 25 plus counties participate. And a big piece there is that was enough counties to give us a representative sample of the state. So I'm not going to read each of these categories, but you can see below where some of the areas of focus of this survey were. And you can imagine, given these questions, how valuable that data is, because these are data that we use, again, at the state level, that coalitions and other providers use, but then also the communities and regions can use. And so prevalence of opioid misuse among students, approximately, and this is our survey, so this is Tennessee specific. It's not one of those national surveys where they maybe surveyed like 950 people in our state. This is Tennessee. Approximately 1 in 10 students reported that they had used prescription drugs not prescribed to them, okay? It says 10%, right? And so looking at the prevalence by gender and grade level, you'll see here, and I'm sorry, sometimes these things are a little smaller on the screen. I actually have to lean in a little bit onto my little computer screen here. But there was a significant difference in use between middle school age youth and high school age youth, as well as between male and female students. Again, this is specific to prescription drugs. It could include, obviously, prescription opioids, but also it could include Xanax, Adderall, Ritalin, and those type of things. And so looking here, if you look at that female category, well, they had the highest percentage of any lifetime use, and highest percentage of past 30-day use. Okay. And you'll note that's a statistically significant difference at that P level specified below. And then also, as you look at ages or grade levels, rather, the big jump was when you went from 8th to 10th. There was not as big of a jump from 10th to 12th. So that kind of tells us something in terms of when our programming needs to happen. It aligns with what kind of I mentioned before. So that's always nice when you see things that align with your thinking. But then also it's that it doesn't change that much from 10th to 12th grade. So that's kind of an interesting aside to where you can structure your program and focus on a group and then potentially do maintenance for the other age groups. So let's see here. So prevalence by race. So overall, you can see we're at what for anytime lifetime use about 8.9%. For past 30-day use, we're at about 3.7% overall. But then when you look at the racial categories, simply put, Black students reported significantly higher rates of use compared to white or Hispanic use in all categories. You can even see there where that past 30-day use is approaching the Hispanic lifetime use. And so, again, that helps us think about our programming and the structure and our focus populations and potentially what does our programming need to look like. Let's see, so prevalence by behavioral health region, planning region, you'll notice Davidson County and Shelby County are not colored in, and that's because we just couldn't do the survey in those systems, which is unfortunate. We continue to work with, but we don't make anybody do anything. So it's voluntary, and we will continue to work with the Shelby school system, and I hope to one day be able to include them. But with what the data that we do have, when you look at it regionally, Region 6 has the highest rates of prescription drug misuse in the past 30 days than any other region, and it's almost double. And so what I would say is I do look at this data and not that Shelby's the same as Region 6, but without Shelby data, the closest thing you're going to get is to Region 6 data. And so that may speak to some potential issues in the Shelby County region. I think the next highest was Region 3 of our state. And you'll note these regions are my department's regions, is the way we think about things. But I think you guys can kind of see clearly where the breaks are, so you can kind of get an idea of what counties are included or not included. So sources of prescription drugs, we have National Take Back Day this weekend, where you can go to your local take back box and drop off unused medication. Sources is very important because the fact is we want to decrease access to prescription drugs. Even if someone doesn't have a substance use disorder, they can't develop one if they can't take it, right? So if you decrease access, prevent diversion, you won't develop a substance use issue. So some of the sources, you'll note about 50% said, hey, I got it from a friend, a relative, or someone they know, okay? And so with that, that tells us, oh, wow, we need to do more messaging on to families and individuals and even to the parents to make sure they understand the risks of having these substances in their homes. Followed by 35% saying they bought from a friend, relative, or someone that they know. And then 27.7% said they got it from a party. And I don't read all of those, but you can see a similar thread to where if we decrease access, you prevent diversion, which in turn prevents substance use. And again, if you're hearing about Take Back Day for the first time, I would say you shoot me an email, I'd talk to you about it. But otherwise, Take Back Day is this weekend, and there are events across the state happening. And then also there are prescription drug take back boxes, permanent ones that are always available. I think we grew that number. They're probably like 30 or so 4 or 5 years ago. We've got more than 330 now, which again is it's really due to the work of these communities. I wouldn't even say it's just coalitions or just sheriffs or just one group. I think it's people realizing there's an issue and we need to decrease access to in our community. So perceived access. I went all that on access, and there's a whole slide on it. Nearly half of all students reported that prescription drugs were either fairly easy or very easy to obtain. And so again, if they think it's readily accessible, there might be something to them just simply thinking that. And so what we have to do with our program, again, is focus on decreasing access to by way of removing it from the system. Let's see, next, perceived approval. Fact is these numbers are high, which is nice. I'd love for them to be 100%, right? but students almost universally agreed that their parents would feel it was wrong or very wrong. You see, we grouped them together to misuse prescription medications, almost 97%. However, you look at that peer disapproval, and simply put, it's lower than the parental disapproval. And you see here where they're broken down by region. And I would say, well, I'm encouraged that these numbers are high. Simply put, you look at region 6, and that perception of approval is lower, or rather disapproval is lower than the other regions. So that gives us an idea of what we maybe need to do more of in region 6 relative to the rest of the state. Perceived risk. I think perception of risk is one of the most important things. I think all this is important, to tell you the truth, you guys. But perception of risk is so that people are in a position to make decisions on their own, right? About 15% of youth perceive little to no risk associated with misusing prescription drugs. Black students were significantly less likely than white or Hispanic students to perceive moderate or great risk associated with misusing prescription drugs. And you can see here how this data aligns with what we've seen before when we see it broken down by race, right? But then again, and I'm broken record on these type of things, you guys, so I apologize, is we know what target populations we need to do a better job with. Fact is, we need to work with all these populations. Don't get me wrong. Every single one of these populations needs messaging, needs education, but we kind of have an idea of who we need to focus more on. Peer use, I think I'm out of time, so I might breeze through. I've got like two more slides, Josh, I promise. Peer use, approximately 12% of students reported that at least one of their closest friends have misused prescription drugs in the past year. And so that gives you an idea of the peers and how they engage and what, hey, this guy's misusing. They may not know, but this is what they're reporting. And last but not least is parent communication. Making sure parents are communicating with their youth. You'll see this note. I actually copied this from one of our documents where 12th graders were least likely to have had these conversations with parents. And so that's the thing where we want to make sure that parents stay engaged with the youth, right? The parents don't feel like, oh, they're 12th grade, I can't tell them anything. That might still be the case, but find a way to engage because there's still value there in preventing substance use. And oh, I had one more, sorry. Exposure to prevention messaging. The good news is they've heard a lot of our messaging. The bad news is again, you can see how all those others, the perception of risk, all those other things aren't as high as we want. So maybe we need to think about the messaging we do distribute. So if you want to look at the rest of the survey, we've got sections on prescription drugs, marijuana, alcohol, tobacco, and e-cigarettes. If you go to the link below, I won't click it because I'm always scared if I click a link, what'll really happen in these type of things. But there are one pagers, which are easy, quick things to look at. They're super quick. If you don't do anything, maybe just look at those one pagers. And there's a compendium. If you're somebody like me and you do like the data, Josh is right, I love data. You can look at not all of the data, not all of it, because we did make an agreement where we weren't going to share specific community level or school level data, but you can see almost as much of the data we can share. And last but not least, there's my contact information. If you want to reach out, you have questions, issues, concerns, I said something that was confusing, didn't make sense, or you want to learn more about some of the stuff, please don't hesitate to reach out. I'm sometimes slow to respond, but I promise I will respond. And with that, Josh, I will cede it back to you.